Good morning, everyone.
She was going to ring the bell. I told her not.
I wanted to ring the bell. She's a spoil sport. Is everybody here? Do you know? Are we missing anybody, or is this most people? Well, good morning. I am Ruth Hannah, and this is Lisa English, and we're the paediatric practice educators for the trust. So Lisa is based quite a bit more in A2, which I know a lot of you will see more of her, and then I would work between A2 and Causeway. So I met lovely Beth yesterday. So we've just been asked to give some of the theoretical training that we deliver to a lot of the nursing staff, but that is still applicable to you. So this morning's session with us will be looking at central venous access devices and give you a little chance to practice in simulation. And then I'm going to hand over to Lisa, and she's going to take you through tracheostomy management, and she's the queen of tracheas. So you've got the best person here. So we'll just get started. I have to be sensible because we're being recorded, and that isn't flicking across. There isn't that flicking across. Upside down. Do I just go down? Doesn't it? Yeah. Okay. So the aims of our session here then is, by the end of the session, you should all be able to describe, if you don't know already, what an implantable port is and where it's sited and how it's accessed, and be able to list the reasons that you would have a CVAD, and to demonstrate through simulation how to prepare for and to access an implantable port, and to discuss any arising problems that can come out of that. So first of all, just a little recap, and I know it's kind of like teaching grandma how to suck eggs, but we'll just go through it for the sake of completeness. So a long-term CVAD is a catheter that's inserted into the central venous system, and the tip is inserted into the right-hand side of the heart. So you've got different types of CVAD, and in the past we would have seen more of these, the PICC lines, peripherally inserted central catheters, and the Hickman-Broviacs, which are the skin tunneled ones, and they would have been sort of commonly referred to as Mr. Wiggly. But a lot more now are coming out with from the Royal with these subcutaneous implanted ports. In fact, I think unless there's a contraindication, the majority of them are coming out with these ports now. And so that's why there's been a big emphasis on understanding and being trained in how to access them. So just to revisit some that you may have already seen in your practice, you've got the PICC line, which is obviously entering in the arm, the skin tunnel that's entering in the chest. And then we have got what is sort of commonly called the Portacath, which sits just underneath the skin. So an implantable port is still a central line, and it could be referred as just a port, Portacath, or a TVAD, the totally implantable venous access. So you'll see each of those being used in practice. So that small chamber, which you'll have opportunity to have a look at in a moment, sits under the skin and is attached to a catheter that threads from the internal jugular vein through into the right side of the heart. And in adults, it's sort of, you have to feel for it, but in kids, a lot of the time you can actually see it, unless they're maybe a larger child. So you feel for it, or you can roughly see it in a lot of the kids that I've seen them in. So how it's inserted, these would all be inserted in sick children's in the Royal under general anaesthetic, and it just involves the two small cuts in the chest, one to make the pocket for the portacath to sit in, and the other just to insert the catheter into the internal jugular vein, and they x-ray to confirm placement. So there's a couple of different types in terms of visuals, but they do exactly the same thing. We've got the round one, white one at the bottom, and that's the one we would see a lot more of and typically would be seen in children's. And before, when I was giving this presentation, I'd have said the purple triangular one was more one that you would see in adults, but we've actually had one in Causeway in a small child recently that was this purple triangle, so they must be making them smaller as well. So they're made with silicone and titanium. There's a variety of sizes of port and catheter, and you know, you're not making any of those decisions. That will have all been done by the surgeons in the Royal. There's usually a single port, but there can be a double. I've never seen a double port in practice. I think it's less common. And I say you can have the round or the triangular, and they've got location dots on, which you can kind of see on the top one where they are. So they're your markers to feel for. So the septum, which is the center section, is self-healing. So even when it's being accessed numerous times, it doesn't get damaged in the same way, and the surrounding area is a hard frame. So these can stay in for 5 to 10 years, and when you are accessing them and flushing them, it's really important how you do that, because it's the technique of flushing that's going to keep this line patent. So it is always used with a push-pause technique to create turbulence to clear the line. So what is it used for? So it's commonly used for access, obviously easy and reliable access for the child or young person's bloodstream. So this would be for the wee ones that are on long-term treatments, or maybe have got really, really horrific access. And so it's just a more sustainable access point. They can be used for taking regular blood samples and for IV medication that's been administered on a long-term basis. So the likes of sort of chemotherapy and different stuff like that. So a gripper needle, which you'll see in a moment, but it's illustrated there, inserts into the chamber, and the blood can be withdrawn and the medication given as the drug travels from the chamber through the catheter and the bloodstream. I've got some set out there, Lisa, at the... Oh yeah, at that, perfect. So the pros and cons of these, there's always pros and cons with anything, I suppose, but yeah, Lisa's just passing around what the gripper needle actually looks like. Is the patient's acceptance of it and their body image, especially for older children. There's no exit site dressing, so that allows like those really important things like bathing and swimming for kids, so they can be normalised, their behaviour can be normalised a little bit more. And there's less flushing and no dressing change, so there's less maintenance. But you do still need to puncture through the skin to access the port, so you still do have the children crying sometimes when you're accessing it, which can lead to that little local skin ulceration. And they tend to have a shorter lifespan than tunneled. And of course, it requires that general anaesthetic and operation for it to be placed. So the needle that's pass-drained is the Huber needle, and the key thing, the take home, is you have to use this Huber non-coring needle. A standard hypodermic needle can't be used because it's not non-coring. So as you're putting it in, every time you put it in, tiny little particles break off, and so that would break off little bits of the septum that could then be introduced into the patient's bloodstream. So it's really important to use the non-coring gripper needle. So non-coring is just that it won't cause damage to the septum. The other thing to note, the needle obviously in the pack comes with the extension on it, and it's really important to have that primed with your saline prior to accessing the port, because obviously we don't want to introduce any air at all. So you have to have that primed before you start accessing. Once the needle is in place, you'll see when we've got the ones that are open, there's like a little butterfly that helps you hold it as you insert it. But once it's in, those wings just can clip off. And so if it does need to be left in, we've had one recently in AT that, was it fluids they were on? And so those wings are taken off and just an IV 3000 put over the top, and that can be continually used. And that same port needle could stay in situ for up to 7 days. And so you just need to make sure that everything's done with that sterile barrier of the IV 3000. So the things to think about, and the good thing about Encompass is that you should readily be able to find all the information that you need. The information from the Royal should come down about the needle length and things like that. So it shouldn't be any guesswork. If you've got too short a needle, then you may not actually pierce through right the way through, and there could be extravasation. And if it's too long a needle, and we can show you that when you are practicing, if it's too long, then it's left rocking and there's movement in it, and that can tilt and come out of position. This isn't a great example here. We hate this, but it's sort of the best in showing that if you were leaving it in. Now, this yellow little butterfly here is quite an outdated one now, that you wouldn't see that. But it's the same principle, that if you were leaving the needle in and there was any movement at all with the needle, you could actually just secure it with a little bit of sterile gauze around it and then put your IV 3000 over the top. The key thing is to make sure that it is the clear covering, because you need to, like any line, you want to be checking for signs of redness or tracking. So the basic principles is of, you will know this, your 7-step hand washing technique. We all know that when we're, especially with central lines, we have to be, hygiene has to be impeccable, because it can so easily get infected. So hand hygiene is really important, and if it is staying in and there is a dressing on, just making sure that stays dry and intact. So there's a lot of discussion about the type of aseptic non-touch technique is used for different types of access, but this one is definitely the strict surgical aseptic non-touch technique. If you're not familiar with it, this website here, which handily enough is www.antt.org, has every sort of scenario of what you would be doing and what type of ANTT you should be doing. And so there is one particularly for insertion into Portacaths there. So it's strict. So if you haven't done it for a while, or you're just not sure that you're doing it right, just revisit that, because it is really important when you're accessing a port. So we'll go through, and my glamorous assistant is going to do the practical bit while I'm speaking. So the first thing we do is prepare. So you're gathering all the equipment that you would need and thinking about it in advance. So you're preparing your sterile field. So obviously part of your ANTT is that you're washing your hands thoroughly. You're cleaning the trolley. Yeah, she's washed her hands and you've cleaned the trolley. You've got a dressing pack, and that's opened using that same technique of just touching the outside glue. You don't snatch off the off the sterile bit. Take them off. And that field is kept sterile, and as Lisa's demonstrating beautifully there, you just open outways your everything that you'll need for the procedure onto the sterile field. It's very, very frustrating, and we've all done it, where you've kind of got your sterile field and you've got your gloves on, and then you've forgotten something and there's no one around to go and run for it, So do think about getting everything in line. You've got the second layer underneath your trolley where you can store things, but ordinarily there's probably a very helpful nurse around to be guiding you as well. The key thing is, just to remind you again, is to have that port primed. So Lisa has opened up, she's sterile, yeah. She's opened her hubber needle, and she is flushing the line so that there is no air, and then she's clamping that off. So that happens before you do anything else. And then just to highlight that a 10 ml syringe is the absolute smallest you'd ever use, just because of the issues with pressure blowing the catheter. So 10 ml or greater in regards to the size. And the next thing that you do, and this is before you scrubbed and got your gloves on and all the rest, is to locate the port. So if we flop it down for a second to show you what this is feeling, that's where it's sitting. So you're feeling for those markers with the round one, you can just generally feel the round one. For the triangular one, whoever was accessing that one in Causeway the other day said they found it harder to find, but there is those little markers. So just feel for those and check the site. Now, I have seen a video that actually says once you have kind of found the point, some people actually put like a little Clinell wipe almost as a pointer above it to say like it was here, so you don't have to keep messing with it again. That's a tip. I've never actually seen anybody do that, but I'd say, oh, that's beautiful, Lisa. Beautiful. So, and of course, the other thing that Lisa has done there as she's feeling for the site is that she's actually looking, is there any redness? Is there any swelling? Is the child, no, it's difficult with children. For those who you haven't done a children's placement yet, they squeal just because you're in the room. It not necessarily shows pain, but if you feel like they were very happy with you touching everything else, and then as you press in, they show pain, you know, normal things that you'd be looking at with your line when you're identifying the position of it. This is really important, the position of the patient, and they need to be against something, whether that be the couch that they're on or on mommy's lap or whatever. They need to be against something, because if you think you're pushing quite hard in, so if there's nothing behind them, the child's just going to go back and you're not actually going to get through. So the position of the patient is important too. And, you know, and it's thinking about things in children's like, you know, mom's probably seen this 100 times. What works best? What position do you normally use? What are they less troubled by? And then once you've then got, so you've got your sterile feed, you've got everything ready, you've located the port and you've positioned the child. Now you go and repeat the hand washing process, and you're done your PPE and your sterile gloves. First thing you do is to clean the port site with the ChloraPrep applicator. So you will all know, you click that and then you clean for, now Lisa's come up with this brilliant analogy. Right, go for it, Lisa. Yeah, that as you're cleaning, you're making the germs drunk. 30 seconds, they're drunk. And the 30 seconds drying is them dying, basically. So the drying is as important. Yeah, the drying is as important as the actual cleaning. So then you remove the needle guard and relocate the port, trying not to touch those key parts again. So this is where I suppose having your pointer of your Clinell wipe would just help you. So you're trying not to, you know, be squishing. Show a bad technique, Lisa, where you would like pushing all over the port. You'd be trying to, yes, identify it with the 2 index fingers. Like, yes, that's recorded, Lisa. So holding the needle in the dominant hand, you stabilize the port, as Lisa's shown, between the forefinger and the index finger of the non-dominant hand, and then you insert the needle at 90 degrees angle. So there's literally no huge technique for that. If you've marked it 8, you're just pushing straight in until you feel the needle touch the back plate. Now, in a difficult insertion, if you try and push in and you can't push, you could be hitting the surrounding hard edge. That's your first thought, but there can be other reasons which we'll go on to. So if you feel like, no, that's not pushing in at all, is just gently remove it, and then you can try again. There is, because you're going through skin, you know, there is a little bit of pressure that is needed to go through. Once you're in, then you've got your you can attach your empty syringe. If we use an example here that we're going to take bloods, and we're going to check for a flashback. So we're unclamping, and then Lisa's pulling back to check that the catheter's in the right place by getting a flashback. Children's lines will have been locked with 4 mils of heparin, and so we take at least 4 mils back out and discard it to make sure the line's clear of the heparin. Once we've got that, we know it's in the right place, we've got our flashback and we've discarded, we can then either, you know, kids could come in just to have their line flushed. So then you'd just be flushing. Lisa's demonstrating that lovely turbulent push pause. And then locking. You could be giving a medication and then flushing. Whatever you're giving, use that same pulsatile technique. The one thing that we really want to emphasize, hence it being circled here, there isn't any Northern Trust specific guidelines for CVADs, but it is widely accepted that we use the Belfast Sick Children's guideline. So on most of the areas you've got this large poster, but I've zoomed in on the one that's for the port. So it's reminding you, withdraw the 4 mils of blood and discard it. If that, if you've done your flush, you've given your medication, or you're just flushing the line and you give your flush, if you know that that's going to be used maybe later on today or tomorrow, then you would lock with 4 mils of heparin of the 10 units per mil. So the weaker one, because it's going to be accessed again. If they're coming in for their monthly line flush, and so you've got your flashback, you've taken your 4, you've flushed it with saline, now you are locking it with the 4 mils of 100 units in the mil of the heparin sodium. So large difference in the dose. So just be aware of that. And I would say maybe in Causeway more, you would see them more for just the flushes or taking the occasional blood. So you're normally locking it with the bigger amount. But if you've got one like on the ward that maybe it's in more use, then you would lock it with the 10 units per mil of heparin sodium. Yeah. Okay, so with 2 strengths of heparin sodium to lock. So you've got the vial that is 10 units in a mil, and you've got one that's 100 units in a mil, a much stronger strength. So if there's going to be a long period of time, say the 4 weeks, until you're accessing it again, the stronger strength is good. It's fine. It's going to keep it hopefully patent for that length of time till it's flushed again. But if you're going to access it in a short space of time, then you want to go for the weaker strength, because if you were given the stronger strength a couple of times a day or every day, then that's going to be, become a problem because of the amount of heparin you're introducing. So if you just think of it, if it's for a short lock, then it's the 10 units in a mil. If it's for a longer lock, you use the strong strength of 100 units. Happy enough? I know it's fair, but
you always want to control. That's what we only ever go sit in the line. It's never going to go with the circulation. So
yeah,
I did like a little bit.
Yeah,
that's where you always withdraw the forward.
Yeah. And
always remember the start those ones that people have set back for blood.
Oh gosh.
The range.
Yeah. So that's literally just to keep the line patent.
They're already with things, they're already used or even based on the weight of the time.
No, it just goes to this. It's the protocol, just but because it's the size of the line. Yeah. No.
It's just more. Which does seem a bit strange in these, because everything else is weight related, but
yeah,
they've all got similar size.
Yeah. And that guidance doesn't offer anything on weight differential at all. So as Lisa said, it's the 4 mils, because it's not, you're not actually introducing it to the child. It is just the length of the line that you're thinning. but it's not something that you instinctively are always going to remember initially. So in both clinical areas, if you just look for that RBHSC guideline and just be checking with that whenever you're accessing.
The nurses on the ward access it, or do we?
Yeah, we'll go on to we'll discuss that at the end, because that's a hot topic, but we'll speak about it at the end, because there can be a reliance on the doctors to think, well, that's okay, the girls will know how to do it, and so, you know, whatever, but we'll speak of that at the end.
I mean, I was in ICU and the nurses would all, like, we would know if the nurse told us to do it,
Yeah.
but I take it not.
They would have done competencies to,
There is, of course,
yeah.
I will say, here recently,
Yeah, that's so true.
so she came to the ward, nobody had access to her ward, no, that was a big issue. So I've always done this training for the last couple of years, so somebody needs to be able to access support. And also if they're in ED, nobody in ED will access it for you.
Yeah.
Somebody comes in a recess, even some of those hematology patients reports, we have collapse that come in here when they go to Belfast. So you always would kind of need to know how to do it on the ward. We have pushed really hard to try and get everybody trained and caused by that day too. It's an ongoing process.
There's only going to be a few, so it's going to depend on if you just have someone that's trained. The difficulty can be with the nursing staff. You know, once you feel you're competent, you can go on ahead. But with the nursing staff, even if they have to have had a certain amount of sessions doing it in front of somebody that is competent to sign them off. And it's quite hard to get a lot of people signed off because it doesn't happen that often, so it can be a challenge. We try and get some of the ward staff to even go with the community staff out and get them that way, but it is difficult. So we do have, I think there's three and three from each areas are going out now to the next round of training, but they won't be able to do it until they've had all their competencies signed off. So what we're saying is don't heavily rely on the nurses, and they should refuse, but it wouldn't be fair to put them in the position of pushing them to do it when they're not competent.
So another issue, first day, if you access that from everybody, she's like, not really, but so I'm like, yeah, she had to get purple hands, but both 19 for her.
No, it
So
wasn't.
it was terrible.
Yeah.
So the work you might then.
Yeah. The other thing just to notice, and Lisa did do it, but I was talking about something else, is to finish off your flush on positive pressure, because that just helps minimise the reflux of blood into the tip of the catheter that could create a clot and block it. So as you're doing your last push, you clamp, so there's positive pressure. Yeah. Okay, so when flushing then, remember your pulsatile technique to create turbulence. As you're pushing, Lisa was observing the site for any swelling, just in case, that had moved position, because pain or swelling could obviously indicate a misplaced needle. And if resistance is felt when you're first inserting, you check that the needle's located correctly and is touching the back of the portacath, and that you've released the clamp, because you look very stupid if you go and fetch your consultant and say, this is blocked, and they unclamp your line. The reason for touching that is, if you think the space that's between it, and where the needle opens, if you haven't pushed far enough through, the actual septum will be blocking, the exit of the needle. So it doesn't, you don't want to hammer it in, but you want to have connected with the back of it. But if there's any doubt that it's in the incorrect site, you can remove it and site a new one. The possible problems you're always thinking of with any line, and would just to highlight, think sepsis. If there is any question about that line, that would be the first thing you'd think of. The line may be blocked. There could be a blood clot, which is why that's the technique that you use for flushing is so important. The portacath may split, but that is quite rare. But we would have also been told that the port flipping or moving is quite rare, but
Our one has fallen off, so
yeah.
it's possible.
Yeah. So, but we have been in a situation in the last 12 months when we've heard about 4 or 5 that are flipped when they've been accessed. So instead of hitting the septum, you're just hitting the back of it. Yeah. So you don't flip it back.
Why do you not flip it back?
Yeah.
We do have one girl from East London CCM who has support for really her access. She's complex health, and hers, her one we just rang one day and said she has a nice little line coming out of her neck, and you can see it. And we were, oh, maybe we could go to the Royal for that. So she went, and you could clearly see the tubing like this, sitting like in a big loop, just obviously up in her external jugular, and you could palpate it, you could feel it. And I thought, well, that port's definitely come out of the pocket. But actually, when you felt the port, it was fine. And when she was scanned, she had a phenogram. It was just spiraled around, but it was still centrally sighted. I mean, you had to stretch her neck to try and get it so you could get a much on it, but the port was still sitting where it should have been. Hers wasn't flipped, but every other child there's just flipped. I don't think they were suturing them deep enough in the pocket or something initially.
Yeah, and the sutures. Well, we'll go through the causes. So that rotation can occur, you know, if the child has been unwell and has had substantial weight loss since it was put in, and if they were maybe persistently coughing or vomiting, it could have released some of those sutures. But to be fair, the ones that we've seen, there hasn't really been a cause. It just seems to have spontaneously happened. So symptoms might be, but weren't in any that we've seen, increased work of breathing, chest pain, that sense of impending doom, tachy or bradycardia, and a difficult insertion. So I think you would be, you know, you'd be flagging up. You wouldn't be accessing anything if you'd got a child that was showing those symptoms anyway. So you can't see this, it's too tiny, but just to flag up, there's troubleshooting, which you can upload to your phone. The GAIN guidelines, they seem really out of date because it's 2014, but there hasn't been any newer ones since. And that just takes you through the problem, the action, and the investigation that's required. So, you know, we can see here that if there's a total occlusion, it's for surgical review. It's out of our hands, because a lot that needs to be properly replaced or turned by somebody that is competent to do so. And they would need to do the scan to see what was happening there. So they're good to know, but you'll maybe try and think, oh, that's really out of date, but that's the latest ones that you get, and I don't think anything's changed there. So if we're thinking sort of what we're always thinking, or the whole team, is about preventing problems, caution when we're accessing it and when we need to treat. So prevention, you know, at the Sick Children's and, you know, on the ward, you know, and the parents just become the expert, and so they normally are very well educated already about what to look out for and how to care for the port. And then it's that regular monitoring of the site, so checking it, seeing, you know, is everything flushing nicely, is there any redness, you know, is the child spiked to temperature, you know, anything like that is going to prevent future problems. If you're unable to insert the hubber needle or get blood return, which I've seen, you know, it access but can't get a flashback, you should stop and ask for senior help. There are things on those GAIN guidelines, so I'll just flip back, especially this one, the third one down, failure to verify patency. Ask the patient to sit up and lift their arm up and down on the side of the port, and that is really just because that catheter, like any line, could be positional. So a bit of movement or a cough even might help with that. So if you've tried those simple measures and you can't get a flashback, you stop and you escalate. And then under advice from a senior, you follow whatever protocol they're telling you to do for infiltration or extravasation, but most of them need to go up the road and get a catheter grant to be sure.
You don't do any like grants a year? They're all done.
No.
You'd be very lucky to probably young here. There might be someone in that thing, but then first that night, you know, But that's not, it's purely if you need a line, you're just going to pay for it.
And you can't go in and put your guineas down, you know, if it's stopped working and it's blocked, would you put a bit
If the doctors were happy with that, and just were doing it, you know, we're just going to do it routinely, but I mean, if you have experience with them and you're happy, then it gets
Yeah.
more.
There is within those guidelines, it does talk about but that's, I would say under senior direction that would be okay.
If you send them on, it's all
So, this is a little addition that's been put in now because of the Encompass documentation. So when that is placed in the Royal, technically, whoever placed it should have then put it onto the avatar. And you can see here, single lumen implantable port, right chest. It gives you your descriptors there. It will have the date that it was put in, who put it in, the sizes, all of that information will be there, hopefully. But ongoingly, if you were accessing then this port, is just to remember that you are going in to assess, and you may have done this and seen this already, but just to highlight, you're hovering over the line and you can see here it's got remove or assess. So you just click on assess, and if you're accessing it at all, that leads you into all the questions about the date and time that you've accessed it, etc. So you just remember to fill that out any time that it's accessed. And I think sometimes, you know, already you see people forgetting to change it on the avatar. You know, everything's done in the patients and you just relief, it's all done, but it's remembering to go back in. You'd have always documented something before, so continue to do so. Will I play the really rubbish video? I won't say it on camera, but there's somebody else's video, and the woman's got a pair of non-sterile gloves that are about 7 times too big for her, flapping around, so it actually triggers me and Lisa. So
I will say on that panel, use created.
Mhm.
Forget panels, people, whatever. That's not sterile. Procedures, so just be mindful.
So, takeaway points: strict infection control required, surgical ANTT, correct positioning of both the patient against something and location of the port prior to access, preparation of the equipment before you start anything, caution if you've got a difficult insertion, you always need a blood return. And these ports need to be flushed 4-weekly when not in use. And this is the thing just to highlight again, registrants have to complete the CEC course for CVAD training, but then I think it's something like 4 competencies they've got to get before they can be signed off. And therefore don't ask someone to do it if they're not competent to do so. They should say no, but don't put them in that position. If you need support from them, just ask them if they've got those competencies signed off. And again, with yourselves, you don't have to have those technical competencies, but common sense would tell you, do I feel competent to do it? And if you don't, my thing is always ask for someone to observe you, even, you know, for that first time, to give you confidence that what you're doing is correct. And then there is a pile of references where we've got everything from there. Just note, I think I have put that's ANTT, yeah, that's at the top for the procedure guidelines. And the GAIN guidelines is there, so you could save that to your phone as well.